Start solving clinical cases today. For many students and residents, a case-based approach works better, helping them understand the process of becoming a clinician. Unfortunately, the decision to become a clinician may come at a time when classes, rotations, or experiences don't match up with your desire to start solving cases right now. In this book, you'll follow a clinical practitioner who clearly articulates his thought process in providing the best patient care. The book organizes up-to-date management and treatment options by pathophysiologic group, so you can work alongside your class or rotation. You might see the same case day after day, but by hearing what a clinician with 10 years of experience does with complex cases, you can start to develop the advanced skills for better patient care. Each case has review questions to reinforce important, highly tested topics. Instead of hearing dry facts, each case is a story. You can hear how classroom concepts become clinical pearls and reinforce the clinical significance of often difficult to understand concepts. Whether you're trying to study for a board exam, develop additional clinical competence on your commute or between work and classes, or just are curious about what a clinical health practitioner does, this book will not disappoint. I hope you enjoy the journey through these clinical cases and find you can very much make a difference when you have the right tools. Let's explore the thrill of the case. Chapter 1. Case Studies. Gastrointestinal Case Studies. G1. PPIs for NSAID prophylaxis. Case Study. For patients on chronic NSAIDs, using PPIs for GI prophylaxis is a common practice. In the geriatric population especially, there is a significant GI ulcer risk from NSAIDs. The polypharmacy problem is big. Make sure you pay attention to the diagnosis and PPI's intended use. Let's take a look at the case. An 82-year-old female with a past medical history of osteoarthritis, hypertension, hyperlipidemia, and coronary artery disease was experiencing intense osteoarthritic pain. Increases in acetaminophen did not adequately relieve her discomfort. Cold weather exacerbated her condition. The provider wanted to start her on 500 milligrams of naproxen twice daily to help manage the pain. With naproxen, the patient would need GI prophylaxis, 20 milligrams of omeprazole daily, to help prevent an NSAID-induced ulcer. The patient started the naproxen with minor relief, and the primary provider started tramadol as needed. At this point, the patient stopped taking naproxen. After that, she was hospitalized for a non-pain-related reason, but was never told to discontinue the proton pump inhibitor, PPI. After her discharge from the hospital, physicians clarified a new diagnosis for the omeprazole, GERD. However, the patient had never had a GI problem before. So this case study is a classic example of the healthcare team not paying attention. I cannot overemphasize the importance of procuring an accurate, comprehensive patient history. Constant reassessment of medications during each visit is also crucial for preventing polypharmacy. So let's take a look at a few questions. How do PPIs help in NSAID-induced ulcer prophylaxis? The answer is proton pump inhibitors, PPIs, help heal NSAID-associated ulcers by inhibiting gastric acid secretion. Next, what other medicines are choices for NSAID-associated ulcer prophylaxis? The answer, misoprostol, brand Cytotec, seldom used due to GI adverse effects like diarrhea, and H2RAs like famotidine or ranitidine. And finally, what could have prevented the GERD diagnosis? The answer is medication reconciliation happens when a patient comes to the hospital, and knowing why the patient took the medicine could have clarified the correct diagnosis.